So,
Okay.
hello, everyone. My name is Keith Cornell, and I'm a certified prosthetist. What can I say about myself? I'm the president and owner of an O&P practice called Cornell Orthotics and Prosthetics. We're based in Beverly, Massachusetts. We have another office at Mass General in Danvers, and then we have multiple satellites in the area, including the two Whittier rehabilitation hospitals, one in Bradford and one in Westboro. I'm also the president and founder and inventor of the CJ socket. And this is going to be a little bit of what we're talking about today. It's a topic that's very near and dear to my heart. I've been, again, practicing prosthetics for about 40 years now. And this is probably, without a doubt, one of the biggest improvements to the field that there is. And I'm hoping that the people here listening obviously have an interest in prosthetics. And I'm going to try not to get too sciencey. I'm going to try to keep it as simple to understand as possible. But I really am excited about this. And I hope you guys can catch some of my excitement. Anything else about me? That's enough. All right, so this slide is kind of a disclaimer by Whittier. Let's see, click. There we go. So you'll get one contact hour. Joanne tells me that depending on your whether you're a PT or a nurse, she'll give you the correct contact hours once you do the paperwork at the end of the presentation. So let's talk about prosthetics. And one of the big things I want to start with is the cost. And I'm going to be talking mostly about transfemoral and above the knee prosthetics. But this applies to other levels of amputation and other types of prostheses as well. I'm just going to move something on my slide here so I can see what's going on. There we go. So what you're seeing here is a typical list of procedure codes that we use when we are coding and billing for a transfemoral socket. And we use level 2 codes. These are HCPCS level 2 codes. They're different than level 1 codes in that we pick a base code and then we add all these addition codes to it. It looks like unbundling to some people, but this is how our system works. It's very much like the other DME type L coding that you see. So this first code here, this L5783, is our main code for a replacement socket. And then you add all these things that make this socket unique because everything is so customized. There are test or diagnostic sockets, the material we use is an acrylic resin, the shape of the socket, it could be a narrow medial lateral or ML dimension. There's different features to the socket that are listed here, including the gel liners and things like that that go into it. And the interesting thing is when you look at the bottom total there, and this is a mass Medicare allowable, it's almost $14,000 for a typical transfemoral socket. So that's a lot of money. Thank God there's not a lot of these that are made. But the individual costs are high, even though the frequency of these things is relatively low in healthcare. There are other costs that go into a whole prosthesis, especially transfemoral or above the knee. We have a prosthetic knee. And a prosthetic knee can be super simple and inexpensive, maybe $700 if you call that inexpensive. Or we can have a microprocessor or computer-controlled hydraulic knee with all kinds of built-in algorithmic functions, and they can cost commonly $30,000. And some, quite honestly, can cost more like 2 or 3 times that. The ones that are typically covered by insurance, but they exist out there. Prosthetic feet, the same thing. You can get a very simple prosthetic foot for a few $100s, or you can get one that has, computers in it or motors in it, and you can easily spend up to $12,000 on a single foot. So the total cost of an above-the-knee prosthesis is significant. I mean, on the low end, you're talking maybe $15,000. And on the high end, you can get to 30, 40, 50, 60, $70,000 without too much trouble, depending on the sophistication and the componentry that you build these things into. So what I'm trying to say here is when you make an above the knee prosthesis or any kind of a prosthesis for someone, actually, arms and legs, it's a considerable investment. And everyone has huge expectations from this very expensive device. They expect it, to perform miracles sometimes, like the old joke, are you a good dancer? I don't know what I want to be. If you get the prosthesis, it's still up to you to make it go. The prosthesis certainly helps someone functionally get through their ADLs, but how well they do with it has everything to do with their systemic health. And certainly, the type of prosthesis and the training can make things easier. But still, the main limitation there is the systemic health. So we're going to be talking today about this new procedure code for adjustable sockets, but I need to go back and make sure you understand why this is such a huge deal and why we've been waiting for it for so long. The bottom line is, even though these things are super expensive, you all may have, if you're into prosthetics much at all, know of the failures. People that go through the system, they go and they have all these expectations. You lost your leg, but now you've gone to the hospital, you've met the doctors, the nurses, the physical therapists, the prosthetists. Everyone's working together to give you this prosthetic limb, and the expectation is they're going to get back to their, pre-morbid or pre-amputation kind of status, and it's quite difficult. And even when you educate people, their expectations can be very, very high, and invariably, a certain percentage of these fail. And by fail, I mean they're not used. They're not used with any regularity. It's not really improving the person's quality of life, and it ends up having a very expensive, piece of art deco in their bedroom in front of their dresser, and they get around on crutches because if they have the ability that they can actually be faster and more comfortable. Imagine you can see a picture of this prosthesis down here, and there's this hard plastic socket. In that socket, they put their residual limb or what's left of their thigh into this, and it goes up quite high. It invades the perineum. Many of these sockets actually go an inch or more proximal to the ischial tuberosity. And then that's rubbing and moving along the very tender tissues in the perineum as they're going through their range of motion. If the socket gets in the wrong position or doesn't fit right, it can be quite comfortable. And so, these things are a lot. They're a lot of work. They're difficult to don. I'm going to show you some pictures of that. They're hard to control. They're always going to be more cumbersome, bulky, and hot than wearing nothing. They can cause pain. And when these things happen, people get disillusioned. Their wearing time diminishes. They have unmet expectations. They're frustrated. You didn't make it right. I need something better. Make me a new one. Another $14,000. And if they do this enough and they still don't get their expectations aren't met, then they give up. It's not worth the hassle. There's a huge hassle to any durable medical equipment, and prostheses are just like that. It's very sad when it happens, and it's happened to me many, many times. So many times I think sometimes I'm the worst prosthetist in the country. And here's just some pictures here to give you an example of some of the issues that you get with conventional prosthetic sockets. Here's a fellow, you see the little grumpy from the Snow White on it. They call him grumpy for good reason sometimes. But this is a solid socket. And these are pretty much the most common type sockets you see out there. They're fixed in volume, they're fixed in dimensions. So the anterior posterior dimension is fixed, the medial lateral dimension is fixed, and there's a lot of science that goes into these things, but that doesn't mean it's comfortable. And you see him sitting there, and it just goes, punk on this table he's sitting on, or it could be a hard chair, or toilet seat, or whatever it is. Your thigh can't squish like it normally does. And because the socket can't squish, it gets pushed up. And as it gets pushed up, it drives into their abdomen, especially when they're bending over to pick up something that they dropped or something like that. And you can even see the picture to the right here, how oblique the pelvis is. He can't even really sit normally because the prosthesis is so unforgiving that way. And there's other issues there too, besides impinging up in the groin or in the abdomen, it's tearing your clothes, it's marking up your best chairs in the kitchen. And sometimes too, if the socket's too tight and they flex too much, socket wants to get pulled off, and there's this positive distal draw on the soft tissues distally, and it draws fluid and it can actually cause some painful edema if someone's sitting for a long time in a very tight socket. Now, for some people, if they can get up and they can walk and they can not use ambulatory aids, this is all very much worth that hassle. They'll put up with that. They'll find some way to sit a little crooked or move just right because it's worth it. But there are a lot of marginal patients where it's much more of a tough decision. I want to talk about sockets in general, and the way I like to talk about this is a prosthetic socket has some two main jobs to do. And if I was a socket looking for a job and here's my resume, what would I brag about? Number one, a socket has to be able to provide safe and comfortable weight bearing. In other words, it can't cause injury, it can't be too painful, and it's got to be able to provide weight bearing. I have to be able to stand on this with all my body weight and then some when I'm talking about the forces, concomitant with ambulation. The other main job the socket has to do is it has to provide skeletal control. And by skeletal control, I'm talking about this little two-piece paradigm. It sounds obvious, but the prosthesis and the skeletal segment inside it are two pieces. It becomes almost like a false joint. And imagine, you have a big tumbler of your favorite drink, and inside is a straw. And you can grab that tumbler or that big glass as hard as you want, but you're not going to be able to control that straw. That straw is free to move around in the fluid inside the glass. And that's a good analogy to how a femur is inside a socket surrounded by all the soft tissues and the fluid tissues of the residual limb. It's in an open kinetic chain, if you will. You can't attach or fix the distal end to the prosthetic foot or to the ground. No, standard prosthesis anyway. So how do we control that femur from moving around? And that's what I talk about when I talk about skeletal control. And all sockets have to provide two of these things. So I'm going to take you down a little road here. I promise I won't make it too painful and too long, but I want to explain how a socket ostensibly accomplishes these two things. And when you have a little understanding of that, then you can understand why we're all excited about this new code and adjustable sockets and all that. So here we go. So socket function number one, we'll call this weight bearing. And I call this the cookie cutter problem. So if you look at my cutaway of the femur here, you can see some pretty classic anatomy. The outer surface of the femur and the femoral head is covered with this dense cortical bone. It's very, very strong, but it's very, very heavy. And it's got a large surface area. So it's really good for bearing weight. I can spread the load over a large area. And you see the trabeculi and the cancellous bone there, and all those cell walls line up with the lines of forces. So this bone is as strong as it needs to be, but still as light as it can be. And then as you move down from the femoral neck, past the greater trochanter, you get into the shaft of the femur, the anatomy is very, very different. Now we have this thicker, dense cortical bone. And in the inside, we have, the lumen, where the marrow is in the bone. And if you look at this in cross section from the bottom, I'll make a comparison to this to a cookie cutter. So if you're amputated somewhere mid shaft on the femur, how do you bear weight in the prosthesis? Well, I'm not going to bear weight on that cookie cutter end. That's not going to happen. And the general schools of thought are that you bear weight somehow on the pelvis. So you'd make a shelf that the ischial tuberosity would sit on. And that looks good in the textbook, but in reality, it doesn't work very well. Number one, it's very, very hard for someone to tolerate those kinds of pressures. It's hard to get the socket to displace all the soft tissues, the proximal hamstrings, all the other soft tissues in there to make a secure seat. But even if you do get something that the patient can tolerate, and you can bear tremendous amount of weight on your, just like I'm sitting down and you are too, you're sitting on your tuberosities. As soon as you take a step and the femur goes into flexion, well, now that weight-bearing shelf is a long distance away from the pelvis, the ischial tuberosity, but you still need to apply full weight, you know, as you're going through loading response, the early stance phase, but yet obviously there's no pelvic weight bearing. So something else has to be working, and it's poorly understood. In all honesty, I'm a little embarrassed by my own field for not doing a better job of understanding this and explaining this to people, because it's important for not only prosthetists, but for therapists and nurses and patients to understand how these things really do bear weight. So I'm going to explain to the best of my ability how I believe this works. So imagine you're a little kid and you're in a pig pile. And if you're that little boy at the top of the pig pile, you're having a grand old time because you're just lying on top. And the girl underneath, she's all smiles too, right? But the girl that's third down, she's feeling some significant pressure, and the one even farther down and farther down. And finally, you get enough kids on you, you say, mommy, mommy, get them off. I can't breathe, I'm being squished. And if any of you are scuba divers, this is a real tenet of scuba diving. So the deeper you go in the water, the more pressure there is. It's like the deeper you go in the pig pile. Every water molecule on top of you, like every child lying on top of you in the pig pile, is adding more and more pressure. Now, if you're made of a liquid, you can't compress the liquid, but you can compress the gases. So the air in your lungs can easily get squished. And the deeper you go, as you see my analogy here with the air and the balloon, the deeper the balloon goes, the more it gets compressed and squashed, right? So what does it have anything to do with artificial limbs and weight bearing? I'm going to bring it right back, I hope. I want to talk about buoyancy. And you can't talk about buoyancy without talking about Archimedes, going back to high school. And trust me, I had to look all this up again. But this is actually a statue of Archimedes in Rome. And he's sitting in this bathtub, because this is the story of how Archimedes made his theories on buoyancy. And this is 250 BC, by the way. So he's drawing in the sand. So Archimedes is sitting in the bathtub, and he has some wooden boats floating around with him. And in his hand, he's holding a sizable rock. Let's call it a 5-pound rock in his hand. And as he lowers the rock into the bathtub water, he notices all the boats rise. Now the tide raises all ships. So he calculated that he displaced a certain amount of water, and that the amount of water he displaced was equal to the volume of the rock. And that's pretty commonly understood. What most people don't understand, though, is that also, as the rock went underwater, Archimedes observed that the rock is lighter underwater than it is outside the water. Now that'll make you go, huh, right? How come the rock is lighter? The rock's weight doesn't change, right? Its mass isn't changing. So why is it lighter underwater? Remember going back to my picture of the scuba diver there. So if you see my rock here surrounded by the green arrows, let's say it's submerged underwater, and it doesn't matter the depth, right? There's a certain amount of pressure being forced down at the top of the rock. And that's all the water molecules between the top of the rock and the surface. And then as you get around the sides of the rock and down to the bottom of the rock, there's more and more pressure because there's more water molecules there. And by the time you get to the very bottom of the rock, there's even more pressure there. And it's all pressing on the rock, but it's not the same everywhere. There's more pressure on the bottom of the rock because it's deeper than the top of the rock. And that makes an upward force when they're all zeroed out. And so the rock is actually lighter underwater because the water pressure is forcing it up because the pressure is greater on the bottom than the top of the rock. Now, if the rock was a serviceable boat and the boat could float, the same thing happens. When the boat goes in the water, it displaces a certain amount of water. And again, the same thing is happening up at the surface of the water. There's very little pressure, but the deeper I go, the more pressure there is. And when you sum up all those forces against the hull and the water pressing on it, eventually it makes a sufficient upward force to exactly equal the force of its weight or gravity, pushing it down, and the boat floats. It's now neutrally buoyant. This is buoyancy. And so this is, the principles that I'm going to apply now to prosthetic sockets. I bet you didn't think you were going to hear this tonight. So here we go. As you stand in the socket and your body weight is pushing down, it's like the boat being dropped into the water, right? The socket volume exactly matches the volume of the fluid in the residual limb. And as soon as you press down on it, it's pushing back on the residual limb. Just like my body weight sitting in this chair is being equaled by the chair pushing back up with the same amount of force. And when these pressurized fluids in the residual limb are sufficient enough, you literally float everything inside that envelope of liquid. So the bone is floating, all the organelles and blood vessels and anything else that's in that captured in that fluid is now being pressurized, and it's floating. It's floating in its own fluids. And that's really the concept, one of the major concepts of bearing weight in a prosthetic socket. So, taking you far afield, if you understand that and you buy it, is a flaw with it. And the flaw is that once you pressurize the fluids in that residual limb, you start to move fluids out of the residual limb. So if the interstitial fluid pressure is higher than it is in this capillary here, the semi-permeable capillary, and it's going to force fluid from the interstitial fluids into the capillary and then downstream as the pressure goes to the venous side and eventually back to the vena cava in the heart as it leaves the residual limb. And it's going to be speeding up this venous flow because of the pressure. And that's how, compressive socks work and everything else, right? It also tricks the secondary system, the lymphatic system. Whenever I thought of the lymphatic system, I thought of, your immune system and all this, but the lymphatic system also plays a major role in fluid control in the body. So same thing, when the interstitial fluid is high enough, the lymphatic system says, there must be some edema here, and it starts to take that fluid out and dump it into the subclavian artery, and it's recirculated again. So as soon as you bear weight and you stand in the socket, and now you're pressurizing the fluids of that residual limb, and let's say for the sake of argument, those fluids are now at 2 atmospheres of pressure and the rest of your body is at 1, then you're going to start having a steady loss of fluid in that residual limb, and the volume is going to go down. And when the volume goes down, it soon does not match the volume of the socket, and now your weight-bearing mechanism is delayed. So next time I take a step on the leg and I step back down, instead of getting instantaneous sufficient pressure to float, I'm going to keep on driving down deeper. And eventually, as that continues, you're going to drive deep enough to start having some discomfort, some pain, maybe some bony pressures somewhere. And now eventually you have so much pressure that you can cause an injury or a wound of some type. And this is what we see all day in the world of prosthetics. Patients coming in with poorly fitting sockets, typically because they haven't matched their volume well using socks, whatever else they use to try to maintain this. And then they end up with problems like, pain and wounds. So that's the first job of a socket is bearing weight through this matching of volume, residual limb volume to socket volume. I hope this makes sense to you. Second main job of a socket is what we call skeletal control. Remember, here's my femur wiggling all loose. It's always and forever in an open kinetic chain. So when I fire my hip flexors, it doesn't immediately affect my prosthetic leg. I'm two pieces. Instead, my femur, my distal femur is going to drive anterior when I fire my hip flexors. When I fire my glute medius, my abductor, my femur is going to move laterally. When I fire my hip extensors, the distal end of my femur is going to move posteriorly. And it's going to keep on moving until it meets enough resistance that it starts to affect the prosthesis. And this motion, if you ever see, X-rays of a residual limb inside a prosthesis, it's amazing. So you can see a fluoroscopic study. So it's like a video of someone walking a prosthesis, and boy, that skeletal segment is violently moving around as someone's going through the gait cycle because it's hard to control, and you wonder how patients can even tolerate it sometimes. So there's this whole path that the distal femur takes through the gait cycle, where during loading response, if the femur starts in the middle here at mid stance, mid swing, then at heel strike or loading response, my femur is posterior because I have my hip extensors. At mid stance, my glute medius is firing, it moves lateral, and then at heel off and pre-swing, I'm firing my hip flexors, it's moving anteromedial, and then back in the swing phase, back to the center. And the distal femur is making this crazy path at the inside the socket, hopefully without too much discomfort. But how do we minimize that? How do we control that? Well, that's controlled through the shape of the socket. So if I can make my socket shape so that it limits the amount of motion that the femur can go through at that point in the gait cycle, then I can significantly reduce the amount of motion that the patient experiences overall, and they'll feel much more connected or much more one piece with the socket. So to sum up, sockets have two main jobs. One is weight bearing, and that's done by matching the volume. And the other job is skeletal control, and that's done by the specific shape that the socket takes. So many times we see sockets these days, and they're shaped like my coffee cup here, just a round. They've been made in such a way, and it's kind of an issue because they're not really putting in the shape that might be needed to minimize the skeletal motion in the socket. Okay, so that being said, you're getting a sense of how sockets work, and you're getting a sense of some of the issues that people have when they wear prosthesis. So now comes the good news. Now comes the stuff that I've been waiting for personally for at least 10 or 12 years. And here we go. I'll ask the question, the whole family feud. What's the most common medical reason cited to medically justify a new prosthesis or a socket replacement or even adjustments? And these are very expensive sometimes. New prostheses, new sockets, are thousands of dollars, and even adjustments can get expensive sometimes too when you're modifying these things. And the answer to this is residual limb volume change. And a lot of people are surprised about the amount of changes that occur to a residual limb when they wear a prosthesis after amputation. Immediately following amputation, you have this post-surgical edema. And I'd like to categorize the different mechanisms of residual limb volume change in these three main categories. I call this early residual volume change. And this is, the resolution of the post-surgical edema. And the post-surgical edema is usually significant until the capillary network reestablishes itself, and just the trauma of the surgery. You have a lot of post-surgical edema. Muscle atrophy is pretty well known and understood. If I'm a amputee above the knee, the vast majority of the muscles that are residing in my thigh residual limb typically operate the next distal joint, my knee. So, my quadriceps, my hamstrings, my long adductors are all basically lost their function. And if a muscle doesn't have a work demand on it, and it gets thinner and thinner and thinner. I don't need all this big, thick muscle cell with all these energy, motor, mitochondria, making all this energy if I'm not needed. So, and that's exactly what happens. Muscles atrophy. As the muscles atrophy, not only does the volume go down, the shape of the residual limb changes. And this is very common. And most people understand this. And they talk about, well, your limb's going to shrink for a while, but we'll shrink it up a little bit and then it'll be fine. But that's not true. Because the limb is changing for all kinds of other mechanisms too. On the next category, I call it anytime residual limb volumes, because it can happen anytime during someone's life. 5-10 years after amputation, if you have a significant weight change, gain or loss, it will eventually affect the size of the residual limb, although there's a little mitigation there because the socket's trying to keep you the same size, it'll make you smaller. So even if you gain a lot of weight, the residual limb might not get real big, but eventually it will get too big to go in the socket. Certainly, pregnancy, we see so many women who have a prosthesis above the knee or even below the knee, and they can wear their prosthesis for the first trimester, no problem. Second trimester, maybe. Third trimester, they might not be wearing it because they just gain so much volume in the residual limb. A lot of our patients have metabolic illnesses, renal disease, congestive heart failure. A lot of them have lymphedema, even venous disease. Just the valves and the veins failing as they get older and having these varicosities, holding a certain amount of volume in that distended vein. And then as soon as you apply even a little bit of pressure, not to mention even weight bearing in a socket, but even motor pressure, that volume goes out. And so these things can affect significantly the residual limb volume at any time. And then there's a third category I talk about, which is daily and even hourly residual limb volume change. And these are fast acting stuff. I mean, these are what I call the tidal changes. So you wake up in the morning and you've been a good sleeper, not wearing your prosthesis, and your limb's at this starting ambient size and volume. Then you put on this snug fitting gel liner, and then you stand up in your prosthesis, and all your body weight is pushing down, and you start standing on it and coming off. And every step, you're pressurizing, relaxing. You're making the bed, you're brushing your teeth, you're making your breakfast, you're doing whatever you do. And the more walking you're doing, the more time you spend in weight bearing, just like that picture before, Slow, that increased interstitial fluid pressure is forcing my venous system and my lymphatic system to push fluid out faster than it can be returned. And the more time and the more active anyone spends on their prosthesis, right, these forces are there. And it's forcing fluid out of the residual limb faster than it can be reperfused. So there's a net loss. Now, don't get me wrong. If you guys know amputees, a lot of people get away with it. Their limbs are small volume to begin with. They're very, very healthy, and they can just get away with it. But the forces are still there. Other people, not so lucky. They wake up in the morning, they can barely get their leg on, and by the time dinner comes around, they're wearing a half a drawer full of socks inside there to make up all this lost volume. Other things happen too. You can, just your diet. You can, I like to say, we're all going to finish this, and we don't like my presentation so much that we're going to go out to the nearest Mexican restaurant, and I'm buying margaritas and some nacho cheese dip with tortillas, and we're going to sodium ourselves up as high as we can. And the next morning, if you're wearing a prosthesis, have to get that on, because all that sodium in your system have blown you up like crazy. You have a bad day. And the next day, you say, I'm off the wagon. No salt for me today. And instead, you have 5 cups of coffee, and you just diuresed yourself. So now your limb is smaller than it should be. And alcohol consumption is a similar thing. So, and this is not meant to be a comprehensive list. This is just an idea to tell you all the different mechanisms that cause a residual limb to change significantly in size and shape once the prosthesis is made. Yet, up until, I don't know, 10 years ago, all our prosthetic sockets were fixed in volume, just like this coffee cup here is, you know. And, you know, the prosthetist was expected to make a socket that fit that residual limb despite all this going on. And, you know, sometimes it works, sometimes it doesn't. But the problems are there. So there was a big request in the industry about 10 years ago for adjustable volume sockets. And there have always been a few attempts at it, but they were not very successful. And you see here just a small example of some of the adjustable volume sockets that are available today. These two on the left are prefabricated, one's from Oster, one's from Ottobock, pretty big prosthetic manufacturers. The one in the middle is my socket. I made it bigger and kind of bright to show it off a little bit. And then you have this other one over here on the left with these floating panels, and that is called a BOA or click medical type socket, where you turn a dial and it draws these panels in. And the prosthetist can design those in all kinds of ways to try to make the socket close and open as the patient needs it. And there's another system over here called the socketless socket, which again has these kind of clicky ratchets and straps to try to change the volume of the socket as needed. Now the prefabricated ones, no, they don't see a lot of them. And to be quite honest, one of the big issues here is reimbursement. You know how expensive these things are to begin with. The prefabricated ones already had a procedure code, but it was ancient, and so was the reimbursement. So you didn't see a lot of these being used because in some cases, depending on the contract you have with a third-party payer, you'd actually lose money. But sometimes you did anyway, just because you wanted your patient to be successful and they really wanted it. These other three, the one in the middle and then the two to the right, are much more expensive. They're much more time-consuming to deal with, but they're much nicer. And they tend to fit better. They're not as bulky and more successful, but yet they're cost prohibitive, or had been up until this April. So the increased cost here is several $1,000s, and that would come right out of the bottom line of the prosthetist. So it made it very difficult to get these out to your patients, and they were underused. In all honesty, the industry has underused adjustable volume sockets for this one main reason, and that is there was just no adequate reimbursement. Because I can lose $10 on a prosthesis all day long and never make it up in volume. And even though these things are expensive, they're expensive for a reason, because the cost to make these is extraordinary too. So that being said, leading into the great news here. Finally, and this is April 1st, 2024, Medicare released this new, and this is again a HCPCS level 2 code, and all HCPCS codes have a letter and then 4 digits afterwards. And this is L5783. I am so excited. Addition to lower extremity, should say prosthesis, it's user adjustable. User adjustable means that this is not something that the prosthetist has to do. This is not something like adding a sock or something like that. This is some type of an adjustability that the wearer, the amputee, the user of the prosthesis can adjust. It has to be mechanical. In other words, this is not something that's simply automatic. It's something that's not, just like adding socks or fillers or something like that. There has to be a mechanism that's designed into the socket that allows this to be adjustable in volume. And it's a residual limb volume management system. And if any of you know a lot about prosthetics, this is kind of juxtaposed to elevated vacuum sockets, which have a similar term, limb volume management system. The idea behind elevated vacuum sockets is that they have a vacuum holding the residual limb to the socket, and it forces the residual limb volume to match the socket. It can only be used when you have a very healthy residual limb and one that is already matured. You can't be going through muscle atrophy. You can't have tremendous weight changes. You can't, have, dialysis a few times a week when you're taking off 3, 4, 5 kilos of fluid a few times a week. You'd cause horrific injuries to that person if you put something like that on it. So instead, this residual limb volume management system is to accommodate these changes in limb volume. We're not trying to maintain it. Here, we're trying to accommodate it. So the limb can shrink as much as it does, and the socket's going to be adjusted to it by the wearer, hopefully easily and comfortably. And here's just a list. This is one of our amputee support groups, and some of the issues that these things solve. Number one, first and foremost, trying to find a way to accommodate these labile or fluctuating residual limb volumes. And they can be tremendous, especially when you see these people who are, elderly with, renal failures and pulmonary failures and edema problems that you could be taking diuretics for whatever reason. And the volume changes are tremendous. Comfort, sockets, like I said early on, they have to be comfortable. They have to be worth the hassle. And I don't know if this picture shows it, but I'm sure there are people in that picture who choose not to wear a leg. The lady in purple, way to the right. It's not worth the hassle to her. So she doesn't wear a prosthesis. These adjustable volume sockets are designed to, accommodate the volume, maintain a reasonable level of comfort when you're using it. It has to, right? Also, donning issues. I want to show you a donning issue in a minute. Acceptance. Patient has to make it worth the hassle. They have to accept what it looks like, what it feels like, how hot it is, all those things. And then there's performance, like I said, the weight bearing, the skeletal control, and the suspension. I love this picture. This shows kind of pre and post this procedure code. So the lady up top is sporting her nice onyx black carbon prosthesis, but this is, my coffee cup, right? It is hard. It is unforgiving. It does not let her flesh and blood, God-given thigh squish and move. She can't rub it if she wants to. She can't scratch it if it issues. Once it's in there, she says goodbye to her thigh until she takes it off again. And sitting on something hard is hard. I made a joke. If juxtaposed to this, if you see the lady underneath, right, she's sporting the CJ socket, the one I unabashedly developed. And this is basically a departure. I threw away everything I was taught in school to develop this. And the back half of the socket, the posterior half of the socket, is a textile. And the idea was to make not only the socket adjustable, but to make it less hassly. So it's more like clothing and less like a piece of plastic to wear. Nobody on this call is wearing plastic pants, I'm assuming. Hard plastic pants are not comfortable, but yet that's what we have our amputees wear. And so this is a significant improvement over that, because when she sits, she can sit comfortably. I put this slide in here to show, how much residual limbs need to be adjustable. So here's a fellow who I've known for 30 years plus, maybe 40. And he has a slow growing cancer in the residual limb. The picture way to the left shows him in his existing socket, and he thought it was fine. It slowly grew and grew and grew. The volume of the limb with his tumors slowly grew. He has this giant hunk of tissue hanging up the medial side. We call that an adductor roll. And, he was having some issues inside. I made a clear socket to show him what was wrong. And you can see how he's nowhere near the bottom of the socket, so he was collecting some distal edema there. There's a dressing with a wound on it in the middle of his quadriceps there. There's a tumor on it that's very prominent. It is being squashed, and that's why he has the wound. And then I made him a socket that accommodated all that. So now all that adductor tissue is correctly in the socket. I've accommodated the shape of all his tumors, and he has total contact for better circulation, and he hated it. He wouldn't wear it. And truth be told, even though I tried to convince him to wear this new one, he went back to his old one, insisting it was fine, until he finally got a pretty serious infection and was off his limb and hospitalized for about 3 weeks. Now he's sporting a CJ socket with pride, and he's doing much better. This picture here, and again, just more for dramatize what's going on. Here's a fellow with severe CHF, and this is a standard socket. We want to talk about how you put a socket on. So he has to stand up, do a one-legged set to stand. Balance is to pull that sock through this valve hole in the bottom. He's already out of breath. He's literally, as he bent forward, all that congestion is pushing on his heart and his lungs. He has to stand up and rest a little bit. He's going to try it again. In the end, he never even gets in because he has so much fluid on board. And again, he ended up having to have a newer, larger socket made. Well, this is going to show you a quick video. I hope you can hear it and see it if my internet is fast enough.
Keith, I don't think we can hear that.
Oh, I'm sorry. Can I narrate? Can you hear me if I narrate?
Sure, we can hear everything you're saying.
So he's about 2 months in. He's showing how to put on his first CJ socket. And the thing I want to traumatize here is he's doing this all in sitting. He's not out of breath. He's not working hard. He can do this comfortably while he's seated. And then he'll just adjust these straps, and those straps will adjust the volume of the socket. As his residual limb changes during the day, he simply readjusts those straps. He doesn't have to take it off. He doesn't have to, find socks and like that. And when he's sitting there, he's sitting very comfortably, squishing that sail down. So it's a huge improvement. And what I'm trying to stress here is that many people couldn't have this because they simply couldn't get it paid for. And the cost was so great. Here's another example of a patient who had tremendous lymphedema. And we made him one of these sockets. In the picture way to the left here, you can see how much lymphedema there was. And I couldn't even get the straps around him at first. He came with his physical therapist because he had a PT session downstairs in half an hour and he couldn't get his leg on. And they were going to lose their PT session. They were going to lose their time. You know what these things cost. This is frustrating and time consuming. If the prosthesis can't be used, then how do you make good gains in therapy? So I sat him down, we rolled him up, and in about 20-25 minutes, we kept on successively tightening this thing until we get it all the way on, and he went downstairs and finished his physical therapy. So there's a tremendous need I'm trying to explain, and there's a tremendous value here, and we have been really handicapped to be able to provide these sockets up until this April. And even still, a lot of the insurance companies still haven't adopted the code. Medicare has, because Medicare, basically owns the code set. But it'll take time for all the commercial insurances to adopt this. But we're off to a wonderful start anyway, and we're already seeing a huge increase in the utilization of these sockets, and for good reason. This is just another example of some of the benefits of some of these types of sockets. Here's a fellow sitting down, and you can see how his thigh can squish. All that volume on his leg is being squished out toward the medial side, towards the leg, and the socket stays where it's supposed to be. It's not sticking up into his abdomen when he sits down, and you'll see in a minute how nicely he can kind of bend over and move. And here's this same fellow. He's been walking around the park here. As he's walking around, like I said, he's losing volume because all that time in weight bearing, the fluid, and he's healthy. He's a K4 super active rock climber. But he's lost some volume. So he's going to just readjust this, get another 1/2 inch on each of those straps. Now it fits like he first put it on. As quick, as easy as that. And off he goes. Life is good again. So that's kind of the end goal, what we're trying to accomplish with these types of sockets. All right, what am I doing for time? I'm doing pretty good. I've got
Yeah,
10 minutes
you're
left.
absolutely fine. You have all the time in the world.
Okay.
If you want to follow up with questions after this, that's fine too. Whatever works for you.
Well, good. So this is my last slide. I wanted everyone to know too that if you want to learn more about this, if you want to see more, the Whittier and Cornell are teaming up to put on a wonderful event up at the Bradford Hospital Whittier on September 28th. It's going to be from 10 to 2. We're going to have multiple vendors there, including some of these adjustable volume socket manufacturers. There's going to be a fellow giving amputee golf lessons. He's a PGA golf instructor. We're going to have free food, music. We're going to have a dessert truck. We're going to have lectures presented by Dr. Paul Ligori about wound principles and how to manage wounds. One of the wound nurses is going to be talking about skin care for amputees. There's going to be a lot of giveaways. We're giving away a 55-inch TV. We're giving away some kind of a barbecue thing. I'm not sure exactly what it is. We're giving away cornhole boards. Everyone's going to go away with a bag of stuff, have a lot of fun, and meet some other amputees and hopefully learn something. There's going to be Autoblock will be there, and they're going to having all this material there. So if someone wants to try a new foot or a new knee, there's going to be a good number of prosthetists there that'll let people try things on. So please, if you need any of these flyers, you can contact the Whittier or go to the website and share the information. We're hoping to have a good turnout. A friend of mine down in Tennessee does something similar, and it's very well appreciated by the local community. So I appreciate that. Don't know if I've got 10 minutes or so left. If anyone has any questions, I would love to actually talk to someone rather than myself. So again, I mean, this new code is huge. It not only allows reimbursement for these sockets, but the big thing is it's going to allow them to be put on people who need them finally. And this took 10 years for Medicare to finally approve the code. That's about average for Medicare, I guess. I've got some chats up here. Joanne, you might need to help me here.
Sure. Well, the first one is it says you do amazing work. I never considered the impact of comorbidities and fitting. The second one is actually the link to the eval tool that I sent out to everybody, and I'm
Okay.
hoping that everybody can access that. And then Karen sent a nice compliment too. Thank you for this great information. So I'm going to say this was very well received, Keith. Thank you so very much. We really appreciate your time on this.
Well, you're very welcome. If anyone ever has any questions, by all means, you can hopefully get a hold of me through whatever, LinkedIn, Cornell, CJ Socket, and I'll be glad to help. We do a lot of teaching. We do a lot of observing. We have people go through the clinics all the time to observe and see what we do. So if anyone has any interest in that, by all means, just get a hold of my office and my scheduler, and they'll take care of that.
And another nice compliment. Thank you, Keith. Wonderful presentation. So I'm going to say a very informative presentation. Thank you. So it's
Great.
very well received. Thank you so much.
All right. Well, thank you, everybody, for your kind attention. And I hope you all have a wonderful rest of your summer, and maybe we'll see you on the 28th up in Haverhill.
Sounds wonderful. And my little message to everybody, in the past, sometimes people have had difficulty logging on or clicking on to the eval tool. I will be back in the office on Monday, but I will see your emails and I can try and send them to you if you are having trouble. And I think I know there's a new question on it this time, since we do have the contact hours for physical therapists and nurses. There is a question down there. Just specify directly on the eval tool which one you do need, so I can send you the correct one. Anyways, Keith, thank you so much. And hopefully everybody was able to get the eval tool. And Keith, it sounds like a wonderful event. Love the flyer. And I think it's going to be very successful.
Good, good. Well, have a lovely evening, everyone. I'm signing off then, Joe. I'll talk to you later.
All right. Thanks a bunch. Good night, everybody.
Bye-bye.